Welcome to Pulse&Pressors, where critical care gets crystal clear. Sotalol is a Class 3 antiarrhythmic with non-selective beta-blocking properties used for AFib rhythm maintenance and ventricular arrhythmia suppression. Its major safety concern is QT-prolongation and torsade de pointe, requiring monitored initiation. Sotalol blocks rectifier potassium current, or IKR, and both beta-1 and beta-2 receptors. Its racemic components contribute separately to potassium channel blockade and beta-blockade. Renal clearance and extended half-life in renal dysfunction heavily influence dosing. By prolonging the action potential and refractory period, sotalol stabilizes atrial and ventricular tissue. Beta-blockade reduces heart rate and conduction. These benefits come with predictable QT prolongation and negative inotropy. Sotalol is used for maintaining sinus rhythm after cardioversion and treating documented VTAC. It reduces ICD shocks and may be used off-label in refractory SVT, but is not appropriate for post-MI suppression. IV Sotalol allows monitored loading. The labeled regimen is 75 mg over 5 hours, while EP units may use shorter infusions under strict monitoring. It facilitates safe transition to oral dosing based on QT stability. Oral initiation begins at 80 mg twice a day if renal function is normal. Renal-adjusted dosing is essential, and sotalol is contraindicated for AFib when creatinine clearance less than 40. Severe renal dysfunction carries prohibitive torsade de pointe risk. Sotalol maintains sinus rhythm, reduces arrhythmia recurrence, and decreases ICD shock burden. Compared with amiodarone, it avoids organ toxicity but has higher pro-arrhythmia risk. QT prolongation is dose-dependent, with torsade de pointe most likely during the first 72 hours. Risk increases with electrolyte abnormalities, renal impairment, female sex, and baseline prolonged QT. Major adverse effects include torsade de pointe, bradycardia, AV block, bronchospasm, hypotension, and worsening heart failure. Due to mortality signals in left ventricular dysfunction, initiation requires inpatient monitoring. Contraindications include prolonged baseline QTc, creatinine clearance less than 40 for the AFib indication, heart failure with reduced EF, conduction disease without pacing, significant bronchospasm, and interacting QT prolonging medications. Compared with amiodarone, sotalol has faster onset and fewer systemic toxicities, but higher torsade de pointe risk and clear harm in heart failure with reduced EF. Guidelines reserve sotalol for patients with normal LV function. In AFib, sotalol is a rhythm control agent best suited for paroxysmal AFib without structural disease. It is less durable than amiodarone and requires prior cardioversion and careful QT monitoring. For VT, sotalol can reduce episodes and ICD shocks in selected patients, but is not first-line when structural heart disease is present. Its use is Guideline Class 2B. Optimal potassium and magnesium levels are essential to prevent torsade de pointe. Daily checks and aggressive repletion are mandatory during initiation. Drug interactions that prolong QT or slow conduction heighten torsade de pointe and bradycardia risk. Careful medication reconciliation is required before each dose. Initiation involves baseline ECG and electrolytes, inpatient telemetry for greater than or equal to 3 days, early post-dose ECGs, and continuation only if QTc remains less than 500 milliseconds. Monitoring focuses on continuous ECG, daily QTc, potassium, magnesium, and renal function. Symptoms such as syncope or palpitations warrant immediate reassessment. Torsade de pointe management requires immediate drug cessation, intravenous magnesium, electrolyte normalization, and pacing or isoproterenol for bradycardia-mediated cases. Defibrillation is used when unstable. Sotalol must be started or restarted in a monitored setting. Dose changes require repeated ECG and electrolyte evaluation. It should not be used for acute AFib conversion. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.